Thank you, Dr. Libeskind, and good morning, everyone. It's a pleasure and honor to be here. So I'm Haris Kamal from UT Houston, and we'll be talking about antithrombotic therapy in the world of stroke. Are we done talking? And I'm going to say not quite. There's still a lot of exciting new changes that have come out in our field, almost as exciting as some of the endovascular data that's come out to help us tailor our therapy for our patients. How do I move this forward?
Button.
Oh, the next one here. So I don't have any disclosures. However, I will disclose that I went to residency in Buffalo, New York, where we had more than enough reason to stay put in the hospital, thanks to my mentor, Dr. Siraj, who brought me over to Houston for my stroke fellowship, where we had more reason to stay in the hospital. And you can see why our fellows work so much more. The objectives of this talk, we're going to talk about the data on antiplatelet use, some of the new trials that have come out with some more evidence, and how to personalize therapy for your patient specifically, because it is no longer one size fits all. It really has to be specific patient selection that'll help these patients in the long run. Why is that important? Well, the recurrent stroke incidence, as all of you are aware, still remains very high. So in a lot of studies, the number of ischemic stroke recurrence has been as high as 6.4%, and the risk continues to extend all the way out to 5 years out from stroke. A lot of studies have looked at aspirin. The number of the stroke risk reduction hovers around 17 to 22%, according to most of the data that we have. So how do the AHA guidelines help us in this regard? Well, the 2018 ones give us a level 1A recommendation to start aspirin within 24 hours, but not much more beyond that. The 2019 update from a couple of weeks ago adds another level 1A recommendation to consider using dual therapy based on the chance data as well as a subgroup analysis of the POINT trial that we'll discuss. But some important questions that we see in day-to-day practice remain unanswered. What happens if a patient has atherosclerosis? Probably not a Sampras candidate, but not completely clean vessels. What happens if the patient has a stroke on aspirin? What happens if the patient has a lacunar stroke? Should that be treated the same manner as a thrombotic stroke? So these are important questions that I'm sure you all face every day, and with not a lot of strong guidance. A lot of trials have looked at aspirin diprodamol, clopidogrel. The ATC meta-analysis showed that aspirin reduced the risk of stroke by 17 to 20%. The SP3 study looked at the combination of aspirin and diprodamol and showed that there was an absolute risk reduction of 1% per year compared to aspirin alone. And the Capri trial showed us that Plavix was slightly better than aspirin in the relative risk reduction. The MATCH trial, which combined aspirin and Plavix together versus Plavix alone, or clopidogrel, it really showed us that there was actually an increased trend to harm in these patients when dual therapy was continued for a long period. And the reason for some of these findings were that stroke, a small vessel stroke is a heterogeneous disease. And some of these trials clubbed together all the patients into one category, which may have led to these discordant findings. So I'll start with SPS3 trial, which came out a few years ago. Specifically, they looked at lacunar strokes because these are thought to have a different pathophysiology of lipohydrosis of the smallest vessels, which might be different from a thrombotic stroke. They combined dual therapy to aspirin alone, and they found no difference in the outcomes. And as you can see here, the graph continues to be very similar all the way out to 8 years post-randomization. However, there was double increased risk of bleeding in the dual therapy group. So what we learned is lacunar strokes don't benefit with dual therapy, or probably may not benefit. I'm going to argue that some of the risk factors that play a role in small vessel stroke, besides age risk factors, the biggest risk factor would be the presence and severity of atherosclerosis, and maybe that portends to the biggest risk. The Wasat Trial, which was the first trial to look at intracranial atherosclerosis in its entirety, compared warfarin and aspirin, and really, if you can look at the heavy infliction that happens right at the beginning, after the index stroke, that tells you that there is a high risk of recurrent stroke very early on, as early as the first few weeks. This was mirrored in the Sampras trial. Now, if you superimpose the Sampras medical arm data along with the Wasat data, there was definitely a reduction in the dual therapy group. early on. However, there was still the same infliction. So what that tells you is that it's due to plaque stabilization, that probably with dual therapy that the Sampras patients did better than Wasat. However, there's still that increased risk very, very early on, which is where most of the trials have shown. The CHANCE trial that I'm sure everyone is familiar with looked at high-risk TIAs and minor strokes, and they found a benefit in the dual therapy group compared to the aspirin alone group. And this benefit, despite the fact that they were only treated for 3 weeks, the benefit actually continued all the way out to 90 days with no difference in the bleeding in both the groups. Now, this was a Chinese population, so the thought process was that there's a high chance these patients had a lot more intracranial atherosclerosis than your standard heterogeneous populations. The subgroup analysis based on the different stroke subtypes is still yet to come, so we'll see what that shows. But what was interesting was that in patients who had a single acute infarct, the dual therapy group did not do any better. However, in those who had a shower of strokes, they seemed to do better, which makes some room for thought that it's possible that the patients who had atherosclerosis probably benefited with dual therapy early on. POINT trial, very similar trial, except the dual therapy was continued up to 90 days. There was a benefit in the dual therapy group, however, that was offset with increased hemorrhages. This was a trial that was done in North America, and we'll still look out for the subgroup analysis on how the different stroke subtypes were classified. An interesting trial was following the footsteps of cardiology. Ticagrelor was compared to aspirin, and overall, while there was no difference, a subgroup analysis looked at ipsilateral atherosclerotic disease in a pretty big number of these patients. And when comparing the two arms, it was seen that if you look at the red line here, this is the line with atherosclerosis on ticagrelor. So a significantly lower number of events, while the aspirin alone group did much worse. The patients who had no atherosclerosis did not really have much of a difference, which is the other two lines here. In this subgroup, interestingly, there was a cohort that was on aspirin before they were randomized to the ticagrelor arm. So in effect, these patients were on dual therapy for 7 days because the effect of aspirin continues on. And so these patients seem to do even better in the 7-day observation since randomization in the risk of stroke compared to the patients who remained on aspirin and were on aspirin at home, who had a much higher risk of stroke. So what we are seeing here is that dual therapy with ticagrelor and aspirin may be better for this subgroup of patients who have atherosclerosis, which is moderate to severe. The important thing to remember is these are not Sampras patients. So these were not patients who had a LVO greater than large vessel stenosis greater than 50 or 60%. The TARDIS trial looked at triple therapy and it was stopped early because we found that it does not really help the outcomes. What it does cause is more hemorrhages. So we know that's to be looked at further. Well, the CSPSCOM trial, which was an interesting study because cilastazole has been used a lot in the peripheral vascular disease population, was compared and still is used a lot more in Asia than we use here in the States. So they combined cilastazole with aspirin or Plavix, and they compared it to monotherapy. And this has been looked at previously in the CSPS1 and 2 trials. They decided to make it CSPS.com afterwards. What they found was that there was a significant rate of benefit in the dual therapy group, 4.7% compared to 11.4% in those on monotherapy. And these were patients who had relatively higher degrees of intracranial and extracranial atherosclerotic disease, but all non-cardioembolic. The bleeding rate was similar in really the follow-up, which was all the way out to 4 years here. So this is the all-cause mortality. This is the risk of stroke, and this is the bleeding rates, which continue to be very similar all the way out. Well, the COMPASS trial, which was done with patients with stable atherosclerotic disease and really CAD and PVD, included a subgroup which had patients with previous non-lacunar ischemic strokes. So non-cardioembolic and yet not lacunar strokes. And what they found was that there was almost a 46% risk reduction in the combination of low-dose rivaroxaban and aspirin compared to the medical arm. And this benefit actually continued all the way out to 3 years here on observation. The risk of major bleeding was not any different in the two arms. And so what that tells you is that there may be some role for a low-dose anticoagulation to be combined with an antithrombotic agent for really this treatment of this small vessel disease patient population. The take-home message from the cryptogenic stroke trials, we all know the results of Navigate and Respect ESUS. However, what's interesting is that in even the primary event looking at stroke outcomes, there was no significant difference in the rate of recurrent strokes. And so as you can see here, the graph really continues to be very similar. The graph in Respect ESUS separated out a little bit in the longer phase of the study. However, that was thought to be a smaller subgroup that had more cardiogenic risk factors and higher ages. The bleeding risk obviously was very different in the two sides. So the take-home message really from a lot of this emerging data that we have is that the therapy for non-cardioembolic secondary stroke prevention really needs to be tailored individually for your patients, and we are at a point where we are beyond just aspirin 325, without looking at specifically the age, risk factors, intracranial atherosclerosis, which may be mild to moderate or severe, and the MRI-based pattern of strokes. Strokes associated with moderate to severe intra or extracranial atherosclerosis may benefit with dual therapy, maybe for longer periods like 90 days, and ticagrelor combination may be an option in these as dual therapy. Minor strokes should still be treated with aspirin and Plavix, and especially you can consider dual therapy in the group that had multiple acute infarcts. Lacunar strokes, on the other hand, may benefit with just monotherapy alone. And as I said, the combination of aspirin and low-dose Xarelto can be considered as an option in patients who have some degree of heart disease, so probably an EF of more than 35%, but still not completely clean. Well, a lot of exciting trials coming up. So we're looking at comparing aspirin and ticagrelor versus aspirin in the TAILS trial. Arcadia is looking at specifically at patients with cardiac atrial myopathies. And really some questions remain. Should we start using TEG and platelet function assays in routine practice in patients who we see in the clinics who don't have stents in the brain? Well, I'm going to end on the note that thank you very much. I welcome you all to come visit Buffalo, pictured here on the left, and Houston on the right, both beautiful cities when the time is appropriate. Thank you.